Can you all see my screen now?
Yeah.
So, sorry if everyone for the delay. There was a problem with the internet and the Zoom uptakes. I'm Dr Ramos Takahashi. I'm a second-year general surgery resident in the University of São Paulo. Today, I'm going to present a case of penetrating neck injury that arrived here at our service. From the background, we have a 24 years old male patient that presented here with a gunshot mechanism, trauma mechanism in the zone 2 of cervical regions. The time to arrival at the trauma center was 15 minutes, and the data that we collected in the pre-hospital was the heart rate of 132 beats per minute. The systolic blood pressure was inaudible, and were administered 1 gram of tranexamic acid and a push dose of epinephrine to maintain the hemodynamics of the patients. All of this was administered in the pre-hospital attendant. The patients arrived at our service with a cricoteriotomy that was performed in the pre-hospital care due to the difficulty of ventilation and the impossibility of orotracheal intubation. In the assessments of the B and the ventilatory assessment, we have a respiratory rate of 25 respiratory per minute and a decreased breath sounds on the right thorax. The E-fast was positive with a laying point on the right thorax. In the C, we have a right heart rate of 132 beats per minute, and systolic blood pressure was inaudible, as so as the pre-hospital assessments. The abdomen and the pelvis was normal, and the Glasgow Coma Scale was 3, with the pupils was reactive. In the when we expose the patient, we encounter a cervical gunshot wound at zone 2 with a large hematoma. So we collect a point of laboratory with arterial gas that demonstrate a pH of 6.98 and a lactate of 34. This laboratory had a small problem that we cannot show the base excess and was not available. Here we can show the image of the patient at arrival with the cricoteriotomy, the ventilation with the cricoteriotomy, a large hematoma, and a gunshot in the zone 2 of the cervical region. So I may here a pause to discuss the first management of this patient, what you can think of the next steps.
That's great. Dr. Untracht, can we start with you?
Certainly.
So I would like to know not only about the first assessment and like initial management in this case, but also, do you have any tips for this cricothyroidotomies in emergency setting like this? What are your thoughts on that as well, aside from the first management of the case?
Yes, good, very good question about the cricothyroidotomy. So the entry wound was the left neck zone 2 and no exit wound, right? But
right.
And then the lung point, you mean no sliding on the right, is that right?
That's correct.
Right. Okay. So the bullet traversed the neck and went into the chest on the right side. So he's in obvious shock, lack of base excess. You don't need, because the pH is under 7, the lactate's 32, and it's fine. Airway's fine. If you couldn't intubate him, by all means, go ahead and do the cric. And before I get to the cric, I would say that I would have ordered for this patient some, if you have type O blood, either type specific or type O, low titer O, he needs whole blood, especially with the elevated INR. And how old was he, did you say?
He was approximately 18 years old,
Okay,
24 years old, 24 years
okay,
old.
so he's not on anticoagulants for any reason, to explain that, why because he hadn't gotten fluids. But so I would have gotten blood started to get his blood pressure up and put a chest tube, because he's got a hematoma in the neck, and how much, unless he bled 3 or 4 units into the chest, it's either hypovolemia or a tension pneumothorax. So order blood, quickly decompress the chest, put a chest tube. You already did the cricothyroidotomy, so it's airway, breathing, circulation. So the cricothyroidotomy, chest tube, get blood coming. And for the cricothyroidotomy, you did a great job. You got it in quickly. I do these like a chest tube. It's basically a chest tube. And his neck, you can see it's swollen, and a young, healthy person or someone who's thin like me, you can see the cricothyroid membrane right there. But if you have somebody with a turkey neck or it's fat, it'd be a disaster if you think you can just sort of see it. So what I do is, you try to go just above the cricothyroid or the sternal notch, make a little transverse incision, then put your finger in, just like a chest tube. Feel the cricothyroid, the thyroid, the cricoid cartilage and the thyroid cartilage. You can feel it, and then you just take just like a chest tube. So why you do that? You make an incision between the ribs. You feel it. And the next thing, you take a small pointed hemostat along your finger and pop in, just like you pop into the chest with a Kelly clamp over the top of the rib. You pop into the airway over the top of the cricoid cartilage. And as soon as you do that, you get a rush of air. Just like when you're putting in a chest tube for pneumothorax. You keep that clamp in, take your finger out, then get a size 7 endotracheal tube, or if they have it, a tracheostomy tube, and insert it through the jaws of the clamp, and it'll go down easily, and then you do that in a few seconds. Now they have these kits that you can put in, but I do it the same way. So you make an incision, then you have to feel with your finger, because otherwise you won't find it. If somebody has a lot of tissue there, you got to put your finger in and go right next to your finger. If you're going to use that kit, instead of the hemostat, you take that kit right along your finger, pop in. Otherwise, you're gonna be lost. You do just like a chest tube. So that's that. And so he needs the chest tube and the blood, and off to the OR, because he has hard signs. I don't know if it's expanding or if you can feel a thrill, if it's a pulsatile hematoma. You didn't say, but that's where the money is. And you also have to consider the bullet could have fractured the neck. It depends on whether he has a brainstem injury from, if he's got fractures. But I think right now you want to get his blood pressure up, and then after that, when things settle out, you can take a chest X-ray to see if he has evidence of a fracture of the spine. Then it's a devastating injury, and he's unlikely to recover.
Yeah, that's great tips. And it's so interesting to see that this cric was performed in the pre-hospital setting. So imagine the difficulty that people encounter in these situations at the scene sometimes. So it's very, very hard. Before I'm going to ask a question also to Dr. Kassim, but before I do that, I wanted to ask Dr. André if there were any additional signs or anything that you noticed in the first assessment regarding the hematoma? Was it expanding? Was it a pulsatile mass? Anything that could get us to think that the bleeding, like, is an arterial bleeding or not? So is there anything that you could add in the physical exam before we move with Dr. Kassim?
In fact, the hematoma was pulsatile and demonstrating arterial bleeding, and he was not expanding, I think, because of the size of the hematoma that was considerable, but he was pulsatile.
Perfect. So, Dr. Kassim, I want to ask you a question as well. So now that we have this gunshot wound to the neck, a big hematoma, pulsatile hematoma, but the patient is very, very critical. So with a pH less than 7, inaudible blood pressure, and now we have something that make us consider that he also has a lesion, an injury to the chest, to the right chest. So what happens? Like how much would you go after another source of bleeding, considering that this part of the neck wouldn't be able to accommodate such a huge amount of volume to make this patient so ill? Maybe he has a hemothorax as well, or any other types of injury. What are your thoughts on this approach?
Good morning. So I have a different take on this case, and the thing that impressed me, other than the lack of airway in this patient, that the blood pressure was not audible. So when you encounter somebody like that, the blood pressure is audible, try to palpate the femoral blood pressure or radial blood pressure. If either of these are palpable under your finger, then you know your equipment, or you're not hearing the audible blood pressure sound. And a palpable blood pressure means the patient has a systolic blood pressure of at least 80, between 80 and 60, somewhere there. So that should kind of give you a little time to think of something else, rather than the bleeding being the priority. But if you don't feel that pulse in the femoral or the radial, then you know you're in deep shit. So you need to get on pretty quick. The way I do my cracothyroidomy is, I have the kits available in my ER, and so much so, I also carry a kit in my pocket. And I think it was $240. I personally invested in it, and it reassures me that I will not be in a situation where I cannot do that expeditiously. So I do the same thing like Dr. Untrak mentioned, but my methodology is that I make a transverse incision, longitudinal incision, and get the syringe needle in, put a guide wire through that, and then I do a cut down over it. And I am always successful in getting a endotracheal tube, especially with the kit available in place. And it gives me reassurance that I have done what I intended to do. I did not get lost in a pool of blood or in the maze. Because when you are doing this, your heart rate is pretty high. And even though the patient has a tachycardia of 130, yours will be somewhere around 150 or 160. So be aware of that. And the sequence that I mentioned is something that I was taught, and it is useful. It has been very useful to me over the years. So having done that, if I have secured the airway, then of course, I need to look for where the blood loss has been. But while I am looking for it, it behooves on my part to go ahead, fill the tank up. And like Dr. Untrak mentioned, use the O negative blood if it is available, or type specific. I don't think you will have a type specific because this patient is 24 years old, and he probably does not know what his type is. And O negative will be the choice in this patient. You need to fill the tank up, because once you have secured the airway, you need to get the perfusion going. Otherwise, you won't be successful. Thank you.
That's great. Now, Dr. Untrak, you raise your hand?
Yeah,
Hello.
something occurred to me as Dr. Kassim was speaking.
Yeah.
You mentioned about palpable pulse.
at 11.
Correct.
Okay. I was hearing some other conversation. Anyway, we're talking about palpable pulse, but if I understand Dr. Ramos properly, the hematoma was pulsatile, right? Yes. So
Yes.
I think that counts as a cervical pulse, a carotid pulse. So whatever, but in any event, it's kind of academic because we all agree what the patient needs to have done.
And just another quick question before we move on. So I'm assuming that this patient had his cric because of maybe the expanding hematoma, and the doctors who were there at the scene were thinking about airway obstruction. So that's why they maybe use the cric and try to intubate and use the cric. But would there be another indication to do a intubation or a cric in this scenario? I mean, maybe he has an injury to the airway, and so Dr. Untrak, when would you consider intubating this patient? Maybe like very early at the scene or just arriving at the hospital when we have patients with obvious air injuries, for example, and not only expanding hematoma.
Yeah, I think the judgment to do the cric, I don't think you can criticize it because that's always a possibility that they don't know. The bullet seems to have gone across the neck. They may have actually appreciated that on the scene if they found no breath sounds on the right side with the entry wound on the left. So that's a possibility. And then the other possibility is if the bullet had broken one of the cervical vertebrae, then you have to treat it like an unstable spine. Although if the bullet did fracture a cervical vertebra, probably spinal cord injury is already accomplished and irreversible anyway. And neurosurgeons taught me more than 40 years ago that you try to stabilize the spine, but the airway takes precedence. If you have to intubate them and you have to move, you do what you have to do. I think it'd be reasonable either way. Look with the laryngoscope. If you see blood coming up from the airway, if you're really good at intubating, go ahead. Otherwise, forget it. Do the cric. They had the airway immediately at the scene. You can't criticize them for that, I think, and it was well done. And the airway wasn't the problem; it was secured immediately. So. But all the concerns that you raised would provide another justification for doing the cric, just like somebody with a gunshot like the self-inflicted wounds that destroy just go straight to the cric, or unless you can see the airway directly, severe facial trauma, or this is kind of in that same category.
Great review on crics, right? So very good. So Andre, I think you can move on.
Okay, just to clarify, the O negative blood was urgently administered in the emergency department, and the blood bank was notified to open a massive transfusion protocol. We have here at the trauma bay chest drainage in the 50 right intercostal space using a tubular drain with the in the exit of the immediate blood and pneumothorax and air of the pneumothorax. So we had a hemopneumothorax. We had also administered 1 liter of ringer lactates and 2 red blood cells concentrates. The use of the vasoactive drugs such as norepinephrine and adrenaline was also promptly administered to the patient to maintain his hemodynamics. So due to the clinical instability and the evidence on to cervical injury and the difficulty with the ventilation, the patient was directly referred to the operative room from the trauma bay. Yeah. Here we had another question about the surgical management, the surgical access of these patients.
Great. Dr. Kasim, what about this approach now in this part of the case? Dr. Kasim?
Unmute. Sorry. Can you
No
hear me
problem.
now? Sorry. Yeah.
Yeah, we can.
I have difficulty with my audio today. I apologize. Uh, I agree and concur with what the speaker said. I would definitely look for where the blood loss is. You know, you could lose a liter of blood in the neck, but this patient is crashing. You know, um, he doesn't seem to have any blood pressure as far as I can tell. And so looking for the blood loss because the blood is on the right side of the chest from the left neck injury. You need to assume that it may have caused significant damage with significant blood loss, and that needs to be ascertained by a chest tube. And he may also have tension pneumothorax, like Dr. Untrak mentioned. And you need to do an expeditious chest tube drainage, also relieve the tension if there is one present, and see if you can recover the blood pressure. I think I agree with the speaker. You're right on track. Keep going.
That's great. Dr. Andre, I didn't see any. What was the output of the chest drain?
There was no quantify at the prontuary, but we expect a significant loss with a massive hemothorax. That was the description of the procedure, at least. There was a massive hemothorax, so we consider at least 1,100 mLs of blood.
Okay, so we have the information that there was a significant hemothorax that was drained, right?
Yes, that's
Great.
correct.
Great. Dr. Untracht, any tips in managing this case now?
Yeah, so yeah, that was my question. So you got a liter of blood, and red blood, dark blood. What'd you get? Red blood, bright
There was
blood.
a red blood.
Yeah, and no rush of air, no air leak. Is that it?
No, yeah, that's correct.
Okay. Yes. And
No,
what was the
it's
status?
just a hemothorax.
What was the status of the patient after you transfused the blood? So you should have gotten an audible blood pressure, but after the chest tube and the transfusion, so he should have improved a bit. And I hope that was the case. Was that the case?
He did not improve.
Okay.
We went to the OR with push dose of adrenaline to maintain his hemodynamics.
Yeah, it's better not to have to use adrenaline if he's hypovolemic. But in any event, if he's it seems like the active bleeding is into the chest, and not so much in the neck. So I would have, in this case, I would have started exploring the chest, the right chest, and that's where the problem is going to be, and get that under control. Let his blood pressure come up, and then afterwards. Flatten them out, and you can do an anterolateral thoracotomy, but it's better if you put them up on a side, and then you'd have to turn them supine and then explore the left neck anterior to the sternocleidomastoid, which you can extend across the other side if you need to. But the first step would be to get control of the bleeding through a right thoracotomy.
Dr. Andre, there's a question on the chat. Dr. Edmund Burke is commenting that the patient has a respiratory acidosis and is hypoventilated. And he wants to know if there was an end-tidal CO2 or a capnography checked in the ER to be sure that the crike was actually in the trachea, and if there were any emphysema or any subsequent air leaks.
No, there was no emphysema and no subsequent airway stigmata of trauma. We had capnography in the emergency department, and it was used in this case that demonstrated that the tracheotomy was in the right place. Okay.
Excellent.
Oh my God, I'm about to go!
So, and there, I think you can move on.
So in the OR, we performed a left anterior lateral cervicotomy, identifying the injury in the left internal jugular vein. The initial bleeding control was achieved using vascular clamps, followed by the suturing of the jugular vein with a 5-0 Prolane in a continuous suture. Despite of this first approach, persistent high-volume arterial bleeding was noted, with no identifiable source through the cervicotomy. So we proceed with sternotomy to achieve appropriate arterial bleeding. The time to the OR from the trauma bay was just 5 minutes. It's important because show the importance of well-prepared and team in the emergency department to assess the patients with fast. Here we can show the video of the lesion identified after the sternotomy. We identify a lesion in the carotid artery, the common carotid artery, that was controlled by vascular clamps. We can see there was a significant lesion, the carotid artery, with approximately 60% of the vessel circumference. So, as I was saying, the sternotomy, we identify a large amount of blood in the right pleural cavity and a lesion approximately 1.5 length in the common carotid artery, approximately 9% of the vessel circumference. The proximal and distal control of this vessel was achieved in the vascular surgery team was called intraoperatively. In the second time of the surgery, the vascular surgery team performed a carotid revascularization using an inverted saphenous vein with an end-to-end anastomosis between the left common carotid artery and the saphenous vein with simple running sutures. The total time of the clamp was 1 hour, and the preserved flow in the left internal carotid artery was noted. Here is the final aspect of the reconstruction by the vascular surgery team. And here I can show you a video of the preserved flow after the reconstruction of the vascular team. You can see the pulse of the internal carotid artery and the revascularization with saphenous vein graft.
Excuse me, is that internal carotid artery or is it a common carotid artery?
The revascularization was in the common carotid artery, Doctor.
Right. Yeah.
The pulse was preserved in the internal and the external carotid artery.
So you actually did a saphenous vein graft to the common carotid artery, and the
Yes.
internal and external carotid arteries were spared. Am I right?
Yes, that's correct, Doctor.
Thank you.
So in the third time of the surgery, the general surgery team was returned to perform to review the thoracotomy and the cervicotomy, followed by a tracheostomy using a 8.5 tracheal tube. At this approach, we identify no tracheal, esophageal, or recurrent laryngeal nerve injuries. And a tubular drain was placed in the left pleural space, and 2 silicone span holes were positioned in the superior and inferior mediastinum, externalized throughout the left cervical region. Here we can see the intraoperative fluid resuscitations with 5 liters of crystallite 100 mL of albumin, 9 units of red blood cell concentrates, 4 units of fresh flowing plasma, 1 unit of platelet concentrate, and vasoactive drugs with norepinephrine with maximum dose of 3 micrograms kilo minutes, and vasopressin with the maximum dose of 0.04 international units per minute. The interpretive urine output was just 1,080 mL. Here we can show you a arterial gas that was collected just after the finish of the procedure. We identify that the pH was improved. In the entrance, we know that a pH of 6.9. Now the pH was in 7.43, and the lactate was 17 now. So we can note that the fluid resuscitation and the surgery per se was achieved. The result was achieved with success. The base excess was 3.2, and the other laboratory data was not available. Here we have X-ray of the control of the chest drain in the tracheal tube. Due to the time of the ischemia.
Can I stop you for a second, Andre?
Okay.
So I just want to ask a few questions to Dr. Untracht and Dr. Kassim as well. So the first question I would like to address this to Dr. Untracht is, while I was listening to and seeing the images and listening to the case, I was thinking about actually trying to do a shunt maybe, because the patient was so critical. So Dr. Untracht, what are your thoughts on that and doing a shunt in the left main carotid, the common carotid artery, and also any tips that you might give us to do this in a correct manner?
Yeah, I was thinking that also, because it took an hour to revascularize, but and then I assume that, you know, I'm coming at this from not knowing the other injuries, but I assume that at the time you did that because you knew that that was the only injury. There was nothing else going on in the right chest, and it was good that you thought about doing the median sternotomy, because you can keep the patient supine. And that I wasn't actually thinking that at the time that we were discussing this earlier, but you know, I'd want to know what you found in the right chest. So when you did the sternotomy, you could have looked in the pleura, opened the pleura both sides to see what was there. And if you'd done that and what you found, that's number one. And if you just found blood running down from the neck, then you know that that's the only source of the injury is in the left common carotid. And I would have considered using a shunt at this time and then let the patient warm up, although he may have actually been all better in the OR. He said he was pouring out urine. If he wasn't hypothermic, you know, and he wasn't coagulopathic, then, you know, I think it's okay to spend an hour, if that's the only injury you have, repairing it. Otherwise, I would have put a shunt in and, you know, stop any other bleeding, taken him to the ICU, recover, and then talk about repairing the carotid. The other point is, especially in a young, healthy person, and I wouldn't do this unless you're forced to, unless there was a good reason why you couldn't repair the carotid with a vein graft or patch, whatever. But that injury, you can ligate with impunity, because you probably know this, I'm sure you know this, that the internal carotid on the left would get perfused by collaterals in the face through the external carotid right to left, and then up the internal carotid on the left. So you can do, if it's a devastating injury and the patient got multiple other injuries, and a young healthy patient, or in any patient, if there's back bleeding, you know, if you have back bleeding from the distal cut end of the carotid, then you can just ligate it, because that means that there's collateral flow, and the patient will do fine if that's the, if you're limited to that arterial injury and nothing more complicated. So, but I think in this case, if there was nothing else going on in the chest, it sounds like there wasn't, then I think you did fine. You did the right thing. Only I think you could have done this yourself, Dr. Ramos. Come on. It was right there. Oh, the other point I wanted, two other points. It looked like you could see this from in the neck, that this was just below the bifurcation, just proximal to the bifurcation, that, you could see this before that's the part that you could see normally. You expose that to do a carotid endarterectomy. That's where you get your proximal control. It seems that way. The other thing is, on the x-ray that you did post-op, first of all, there's no cervical vertebral fracture, so that's good for the patient. He was very lucky. The other thing is, it looked like either there was a pneumoperitoneum on the right side, or you have a second chest tube that line is not the diaphragm, but a second chest tube along the base. That if you go back to the last x-ray, I think you know what I'm referring to. It looks like, if you just go back one to your last slide.
The chest X-ray, right?
Yeah.
Yes. Just a minute. Going back here.
Yeah, see that on the right side? It might be just a chest tube. Let me see if I can see that. A second chest tube. It's a second chest tube, isn't it? At the base, where it looks like that radio opaque, that white line paralleling the diaphragm with air under it. But
I think it's a cable from the cardiac monitor.
Oh, is that what it is? Okay, because there's
think
only
so.
one chest tube. Okay, the one chest tube
only one.
Okay, because it looks like it's exiting the rib cage, so it's not a pneumoperitoneum, and you don't see any bullets there, so you don't know what happened to where the bullet is. So no exit wound and nothing on this part of the chest X-ray. But anyway, okay.
Answering your question, doctor, the right pleural cavity was with no injury. We graded the hemothorax just from the bleeding of the neck. Okay, and
great.
And the vascular team was contacted promptly, and the patient was improving in the surgical time. So we did not consider a shunt because of this.
I'm sorry, say again?
We did not consider the shunt because the vascular team was fast in acting, and there was no other lesions identified.
And the patient improved during the OR.
Yeah, I know.
Yes.
I agree with that. I agree with that.
Yeah. Awesome. Great. Dr. Kasim, any thoughts on the surgical approach? Would you do anything different?
I think you have to use some deep thinking here. You have to think about a 24-year-old man who was shot in the neck, and you got 1,000 cc of blood on the left side of the chest, and you already done a trach. What is the probability and what the outcome is going to be the most important two factors that you have to address? So what I would have done is, I would have looked at the chest tube on the right to see if it continues to pour, and after a liter of blood, if it abruptly stops or slows down, I would ignore it. I would not go anywhere near there. Then I would say, hey, the main injury is in the neck, and I would go after it. Instead of doing a median sternotomy, I would do a left neck incision, which is rather quick, expeditious, and I would be looking at where the injury is. And knowing the fact this patient has been hypotensive, number of minutes or hours, whatever it is, considerably longer than that I would like to have been. And I think I certainly would have done a carotid shunt. In other words, I would have turned this case into um, damage control, salvage procedure, rather than using 1 hour of um, valuable time of cerebral perfusion. A shunt would have taken me 2 minutes, and then I would have got out of the OR and then come back some other day to address it. And I would have put the shunt in via the internal common carotid to the internal carotid. Forget all about the external carotid. I might even put a temporary ligature over it, and hope I could have shunted that as well, but it is not necessary. In other words, I will keep my operating room hour to the bare minimum, 5 minutes, 10 minutes, and get out and allow the patient to perfuse his brain, because that is where this patient's problem is going to be later on, and I will try very much to avoid that. I would have done a different procedure altogether. Thank you.
Great comments. Thank you, Dr. Kasim, Dr. Untract. Dr. André, I think you can move on as well.
So the brain CT, due to the time of ischemia, was performed, and we can note that extensive hypodense area in the left frontotemporal parietal zone, consisting with a recent ischemic event in the territory of the left middle cerebral artery. In addition, was a reduction in the size of the left lateral ventricle and the left uncal herniation that we cannot see in the photos. So the neurosurgery team was then contacted and performed immediate decompressive craniectomy. Here we can show the final aspect of the craniotomy performed by the neurosurgery. And the postoperative evolution, the patient on the second postoperative day, following the decompressive craniotomy, performed a follow-up CT to the brain follow-up CT, revealing an hemorrhagic transformation of this ischemia area. The neurosurgery team maintain a conservative management of this hemorrhagic transformation. An upper gastrointestinal endoscopy was conducted for further evaluation, which did not show any new lesions in a nasolateral tube was inserted for feeding the patient. Here we can see the hemorrhagic transformation of that ischemia area. So the patient remained clinically improved despite of these neurological complications, with progression of diet via nasolateral tube until the 5th postoperative day. In the 6th postoperative day, the patient presented with fever and increased respiratory distress. The mediastinal drain became brownish, and the drainage output of this drain was 250 mL. Here we can show the aspect of the drain at this circumstance. We can also see distress in the laboratory data, and with harnish of the leukocyte markers. We have improvement in the leukocyte to 6.7 to 8.48, and a decrease in the renal function of the patients with a creatinine of 0.78 to 1.1. At this point, we performed a follow-up CT to investigate this infectious decrease of the patients. and showing the consolidations with air bronchogram and heterogeneous enhancement associated with ground glass opacities in the lower lung lobes, suggesting an inflammatory or an infectious process, possibly of an aspirative nature. The patients continue with hemodynamic deteriorations with an increase in vasoactive drugs on the 7th day of the trauma. After the trauma, the patient developed bradycardia and gasping, followed by cardiac arrest and death after 26 minutes of resuscitation. We have the injury severity scale of these patients in 29, suggesting a high intensive mechanism of trauma and a bad outcome for him. So that's the case. I'm open for further questions.
Great. Thank you, Dr. André. Dr. Kassim, any final comments on the case? Any suggestions?
So I'm not trying to be impertinent, but I will ask you still. I'll say, so what did you learn from this case?
I think, as you said, Doctor, that maybe a shunt in the first approach would diminish the chance of hemorrhagic transformation and a better neurological outcome for the patient. Also, I think that other conducts in the postoperative evaluation of the patient would better concern the case, like prevention of bronchoaspiration, and maybe the cricoturotomy was not so did not guarantee permanent airway in the transport that the patients evolved with the bad prognosis.
Say that again, sir.
Maybe the cricoturotomy performed in the pre-hospital was not in the good environment to do the cricoturotomy. Of course, the gravity of the case was that there was no other option, but maybe performing the cricoturotomy in the pre-hospital contributes to the bad outcome of this patient, I think.
Yeah.
Yeah, I think that any cric at the scene is very difficult to perform. No one does this as a first attempt for intubation, right? So probably they trying to intubate was very difficult to do that. Maybe the patient aspirating this time, and this complication was shown after 5 or 6 days, or maybe during the surgery as well, and during the tracheostomy. So there are a lot of considerations here to address, actually, but it's an important thing to consider. And I think that the idea of the shunt could at least reduce the risk of having this neurological complication, maybe. And before moving to Dr. Untracht, there's a question on the chat by Dr. Yoshiro Kobe. He's asking, are you suggesting that the complication from which drain showed is mediastinitis? So I think that he's also considering that the patient developed mediastinitis as well. So was that seen in the CT scan, or was it only a lung problem, like a specific lung problem?
No, there was no any signs of mediastinitis. In the brownish appearance of the drain was was in the mediastinal effect, but there was no signs of mediastinitis in the CT.
Because I think Dr. Shiro raised a interesting comment, because it's also a possibility. I mean, you had a sternotomy, you had manipulation of the tissues, and in this emergency surgery, so That's a very, very nice comment, because it's something that we need to address, definitely. Dr. Untracht, any final comments on the case?
Yeah, so I was wondering, where did that very dirty, gunky brown material come from? What was the genesis? Was there, it's coming from the mediastinal drain. So was it a perforation of the visceral pleura on either side that sort of poured out into the mediastinum and then out the drain? Because that, if you'd open the pleura on both sides, I assume during the median sternotomy, is that right? So that would open up the mediastinum to drainage from the lung. It's possible that the patient was getting sort of a pleurisy from the, a pleural effusion that drained through the media. That's possible, and but it's, the CT seems to have eliminated that possibility that there was a missed injury in the mediastinum. Also, with all of these cases, it's really too bad. A young man shot, I don't know if it was someone he knew or what the circumstances were, but in all of these cases, it's important to try and have permission for a post-mortem exam, because then you would know exactly what happened. And it's really, surprising for this lesion. And the vascular surgeons, I think they know about ischemia to the brain, that in a, young, healthy person, there, was there back bleeding when you clamp proximally to the proximal side of the common carotid injury? Was there back bleeding through the wound from distally? You follow my question, Dr. Ramos?
I didn't understand you, sir. Can you repeat, please?
I can translate this in Portuguese.
Sure.
Então, ele está querendo saber se tinha refluxo de sangue pelo distal, entendeu? Se clampeou proximal, será que o distal estava saindo
Okay.
sangue ou não?
No, there was no other lesions identified at the surgery. With the clamps in the proximal and distal regions of the cardiac, there was good blood control of bleeding control of the
Dr.
patient.
Carlos, I don't think Dr. Ramos understood the question.
Yeah. So I'll ask again. Não, mas André, o que ele quer saber é o seguinte: ele quer saber, o importante aqui é ter o refluxo arterial, para saber se ele está comunicando a carótida direita com a esquerda, para ele perfundir o cérebro. Então, se não está vindo sangue distal, mesmo sem clampear, é porque não está perfundindo pelo outro lado, entendeu? É isso que ele quer saber.
There was no reflux in the posterior carotid artery.
Yeah, so I guess that's the issue. Apparently, in this case, as Dr. Kassem pointed out. So, and that's something. What did your vascular surgeon say about this? The one that did the operation in retrospect, after seeing what happened to this poor kid.
They think that the ligation of the artery, the carotid artery, was in fact an option to the patient, but because of the low age, and he was just 24 years old, they considered to perform the revascularization for better neurological outcomes.
Yeah, right. But I mean, in this case, though, ligation would have had the same outcome. But I mean, the decision, the judgment not to put the shunt, and or even even if you went to repair at that operation, you repair with a shunt, and you could repair with a shunt in place. Do that, and to minimize the ischemic time. So, but I think if you say that you clamp proximally and there's no distal blood flow, okay, well, that right there, that's the issue, that something to look for if you're not going to put a shunt, even if for a young patient. But and then the other issue is this: what caused his death, or was it the pneumonia? And what Dr. Carlos said, I think it's the aspiration probably occurred. Maybe the cricothyroid artery was done because he aspirated, but I wouldn't blame the cricothyroidotomy. I don't think that's. I wouldn't come away from this saying, no, don't do crikes if you need it, persist with it. No, do the crike if you need it, especially if they found he aspirated, then they need to prepare ahead for that. I don't know if they're still giving steroids for aspiration. I don't know if that, I guess that whether the antibiotics, prepare for it, early trach, fiber optic trach to bronchoscopy to clear out the airways, aggressively treat that. And then, he probably should have survived the ischemic injury to the brain. He had the neurosurgery for that. And I don't think that would have, he didn't die from that. He died from sepsis, from pulmonary sepsis, it seems. But the real judgment is as Dr. Kassim pointed out, should you have put a shunt in this case? And that's the thing to take away, for the next time, the next young kid that comes in, and you'll be ready because you're here presenting this case. You presenting in front of the whole world this case that had a bad outcome. So, we all have bad outcomes, and it's too bad for this kid and his mom and dad. But you have the intellectual humility and the professionalism to have actually discussed a bad outcome, and that's what I would do next time.
Definitely. So there's a last comment here on the chat by Dr. Edmund Burke, and he says hypotension and poor flow through left internal carotid artery before operation probably caused the ischemia, and repairing the injury might have caused reperfusion injury, which is a nice comment as well. Ligation might have prevented the reperfusion hemorrhage, but who knows? Everything was done well. Injury was high risk. So yeah, I think it's a great comment as well, as considering the reperfusion injuries that we always see in these kinds of cases. Okay, excellent. So everyone, thank you very much for being here today. Thank you, Dr. Untracht and Dr. Kassim, for the comments, and also everyone who participated in the chat. Thank you very much for your comments. Please, if you want to be part of this meeting regularly with comments or presenting cases, just send me a message or send an email to Liliana. So we will make sure to have you on the schedule as well to present on the next meetings. And Dr. André, thank you very much for presenting the case. I hope to see you all next Monday on February for this BITE presentation. So thank you very much. Bye-bye.
Bye. Thank you for the opportunity.